There is a term that surgeons use quietly among themselves. They call it the silent complication. Not the infection, not the blood clot, not the wound that won't close. The anesthesia itself. And if you are over 70, or if someone you love is heading into an operating room in the coming weeks or months, what I am about to share with you may be the single most important thing you hear before that day arrives. Because there is one question almost no one thinks to ask. A question your surgical team will likely never bring up on their own. And by the time this video ends, you will know exactly what that question is, how to say it out loud, and what for specific alternatives exist that could protect the most vital organ in your entire body. Your brain. I am Dr. Joseph, and I need you to stay with me here, because this is genuinely more important than most people ever realize. When people find out they need surgery, they immediately focus on the surgeon, the technique, the success rate of the procedure. They ask whether the doctor is experienced. They search recovery timelines. They worry about the incision, the pain, the first few difficult days afterward. And I completely understand that. Those are real concerns, and I am not dismissing a single one of them. But here's what I have witnessed year after year across 3 decades of working as an anesthesiologist. This one shift in perspective changes absolutely everything. For a patient over 70, the surgery itself is often not the greatest risk. The greatest risk is the type of anesthesia, specifically general anesthesia, the kind that puts you completely under, where your brain is not simply asleep but chemically suppressed to a profound depth, where a tube goes down your throat and a machine takes over the work of breathing for you. For a healthy 40-year-old, the brain recovers cleanly. But for someone over 70, that pharmacological shutdown can trigger something that lingers long after the stitches have dissolved and the wound has healed. The real question is no longer just who is performing my surgery. The real question is, how is my brain being protected during it? Let me explain the biology, because once you understand what is actually happening inside the aging brain during general anesthesia, you cannot unhear it. The brain of a 70-year-old is not the brain of a 40-year-old. This is not about intelligence or weakness. It is about something called cognitive reserve, the brain's built-in buffer, its capacity to absorb a pharmacological shock and return cleanly to baseline afterward. Younger brains have substantial reserve. Older brains have considerably less. The margin is genuinely narrower. When we administer general anesthesia, we deliver induction agents, muscle relaxants, and volatile gases that bind to receptors throughout the entire central nervous system. These drugs do not gently sedate you. They suppress the brain systematically, including the regions responsible for memory, spatial orientation, and sustained attention. And in a patient over 70, the liver and kidneys clear these drugs more slowly, sometimes significantly more slowly. The drugs stay in the system longer than the dosing schedule accounts for. The neurological recovery window stretches in ways that are not always predictable. In roughly 30 to 40% of patients over 70, something emerges in the first 1, 2, 3 days after surgery called post-operative delirium. And I want you to understand what delirium actually looks like in a real person, because the word sounds distant and clinical, and the reality is anything but. The patient wakes up and does not know where they are. They believe they are somewhere from 30 years ago. They become agitated, or they go completely still and unreachable. Sometimes they see things that are not in the room. Sometimes they do not recognize the family members standing right beside them. One daughter described it to me this way after her father's knee surgery. She said he looked at her like she was a stranger. He knew her name when she said it, but his eyes were somewhere else entirely, like the person she knew was standing behind frosted glass. The family had been waiting, expecting someone groggy, but essentially himself. What they found instead was genuinely frightening. And here is what makes this even more serious. Delirium is not always temporary. In a significant number of elderly patients, it is followed by something called post-operative cognitive dysfunction. The memory does not fully come back. Processing speed stays slow. The sharpness that existed before surgery, the clarity, the quickness, the ability to recall names, to follow a conversation, to track several things at once, it is diminished, sometimes for weeks, sometimes for months. In some patients, the evidence suggests the decline does not fully reverse, and consider what this means for a real human life. Someone who was driving independently before the operation, managing their own finances, cooking, living fully, now has family members quietly moving in to help. Conversations begin happening behind closed doors about assisted living. The surgery that was meant to improve their quality of life instead becomes the marker in time when everything changed. Now here is where it gets critically important. And this is the part your surgical team may never tell you. There are 4 specific regional anesthesia techniques, each matched to a different type of surgery, that allow a patient to undergo a major procedure without deep brain suppression. Let me give you all 4 right now. The first is peripheral nerve block. Using real-time ultrasound imaging, a small amount of local anesthetic is placed precisely alongside the target nerve bundle serving the surgical site, whether that is the shoulder, the knee, the hip, or the hand. The entire area goes numb. The brain is not suppressed. The patient breathes independently, can speak, and rests in only the lightest sedation. The block continues working for 12 to 24 hours after surgery, covering that entire critical first day of recovery and dramatically reducing the need for opioids, which carry their own serious cognitive risks in elderly patients. The second is epidural anesthesia, the right approach for larger abdominal or chest operations. A thin catheter placed just outside the spinal membrane delivers local anesthetic continuously throughout the procedure, reducing the general anesthetic load dramatically and protecting the brain from deep chemical suppression. The catheter stays in place for 2 to 3 days, monitoring post-operative pain with precision and a fraction of the systemic drugs that would otherwise be required. The third is spinal anesthesia, distinct from epidural and ideal for surgery of the lower body, including hip fractures, knee procedures, and bladder or prostate operations. A single carefully placed injection creates complete numbness from the waist down for 2 to 4 hours. The patient breathes entirely on their own. No tubian no ventilator, no forced shutdown of consciousness. The fourth technique is conscious sedation, combined with local anesthesia, the appropriate choice for smaller procedures like cataract surgery, carpal tunnel release, or minor hernia repair. The patient is relaxed and calm, not unconscious, not intubated, and the brain carries none of the full pharmacological burden of general anesthesia. Before your next preoperative consultation, write this question down and say it out loud to your team. Ask them directly whether a regional approach is appropriate for your specific procedure to reduce the risk of post-operative delirium and cognitive dysfunction. That question signals that you are informed and it opens a genuine clinical conversation rather than a reflexive dismissal. If you found this valuable, I would ask you to do one simple thing. Share this with someone you know who has a procedure coming up, or with anyone caring for an elderly parent. It takes 30 seconds, and it might genuinely change the conversation they have with their doctor before they walk into that operating room. And if you are not already subscribed to this channel, please subscribe right now. I release detailed, evidence-based medical content regularly. Content designed to give you the kind of informed clarity that changes outcomes. Your brain is worth protecting. Your voice in that consultation room matters more than you know. I am Dr. Joseph, and I will see you in the next one.